Okay.
Got it?
Yes.
Let me know when to start.
All right. There you go, Dr. Graham. So I am pleased to introduce Dr. Leroy Graham, who will be covering racial disparities in COVID and asthma, causes and consequences. Thank you so much, Dr. Graham, for being here today and providing this talk.
Well, thank you for inviting me and holding my hand through the evolving technologies that 67-year-old guys stumble on.
Great. So
All
Dr. Graham, when you're ready to advance the slides, you can just say next slide and I'll go ahead and move it forward.
All right. Well, again, thank you for this opportunity. Today, I'd like to talk to you about racial disparities in COVID and asthma, the causes and the consequences. Next slide, please. These are my disclosures, and none of them have a direct impact on my talk. I will tell you that I am part of a team that has now received our second Patient-Centered Outcome Research Institute grant, PCORI, to study asthma and COVID disparities in both African American and Hispanic Americans. We're very proud to have that work, which is going to continue with the network long after I've moved on. Next slide. So why is this important? Well, 30 million Americans live with asthma. We know that it's the #1 diagnosis in each and every American children's hospital. Sadly, and maybe related, it remains underdiagnosed and undertreated despite multiple iterations of the NHLBI guidelines. There are knowledge gaps that persist among both patients, families, primary care providers who treat asthma in all populations, but this is most notable in minorities and the poor. And these alarmingly persistent disparities continue in prevalence, morbidity, and mortality among children, minorities, and the poor. Next slide. So we're going to talk first about patterns of asthma prevalence. And the thing that always is baffles me is that I've been looking at these data for 25, almost 30 years, and they're not changing a whole lot. So if we look at asthma prevalence, and this is a dated slide, but it hasn't changed. Again, asthma prevalence has grown about 12.3% to 8.2% of the overall population. However, this growth has not been uniform. We know that 17% of African American males, 13.5% of poor children, 13.5% of poor adults, and women at 9.3%. And again, sadly, this does not change for a variety of reasons. Next slide. If we look at utilization, we also see that that's problematic. You know, the female early on is less morbid than the male, but with time actually becomes more morbid. If we look at others compared to whites, we see a different pattern in terms of utilization. If we look at blacks in terms of whites, and we look again at hospitalizations, we see that staggered slide that shows that it's a disproportionate. We also look at the young versus the older, and we know that asthma is more prevalent and seems to be more of a symptomatic problem and an issue with utilization in the young. Next slide. So one of the things, this is an old study, and you know, sometimes when you give talks, everybody feels they have to have the latest and greatest. Well, in asthma, a lot of the bad data is not changing. And this study, though dated, was done by a colleague of mine, Deidre Crocker, in 2009. And I've looked at pieces of this data, and it really has not changed. But in 2009, she interrogated the National Asthma Survey database when she was at the NHLBI. She found that Black children were twice as likely, at 39 versus 19%, for hospitalizations than white children. Black and Hispanic children were less likely to have used an inhaled corticosteroid in the preceding 30 months when compared to white children. And it's important to realize these were children that met guidelines criteria for persistent asthma, and therefore should have been on a control group. Black and Hispanics, we found were more likely to receive daily SABA than white children. And you see that a lot in where there's disparities. There's an over-reliance on quick relief medication. Now, it is fortunate that we finally do have a generic albuterol out there, but again, we have to be resolute in understanding that that is a rescue medicine. Now, interesting enough, emergency room visits positively correlated with SABA use and negatively correlated with ICS use, even when stratified for race and ethnicity. And this is a proof of this kind of dysfunctional treatment that occurs in these groups. So one of the things that I learned about as I got into looking at more disparities is the power of looking at the psychological aspects. So research in psychology tells us that when you believe you can do something successfully, you can do it more often. if you are more persistent in the face of difficulty as well. So think about this, an asthma attack in a family. You want to be confident in applying the therapy, and you want to be persistent in the face of difficulty. Well, in reality, many families, for a variety of reasons, more often in minorities and the poor, lack confidence that they can carry out provider recommendations and effectively manage asthma at home. And I had several patients like this. And I say, you keep coming to the emergency room, and they'd say, well, that's where my baby gets fixed. And so we have to go back and look at what was the disconnect there. Sometimes it was a management plan. Sometimes it was teaching technique, but these things do persist. Next slide. Well, self-determinism, and again, I'm straying out of my field, but I like to read, is an individual's belief that they are capable of completing a task and thereby reaching a set goal. Well, self-determinism, which is actually self-efficacy, is measured by a validated scale called CASE, and it's low. It's notably low in urban Blacks with asthma. So what does that mean? It means that people at the time that they really need to kick in, their ability or their belief that what they do can make a difference is fairly low. And I think this is an indictment of how we teach people. And we don't necessarily empower people as much as we try and give them a list of facts and expect them to run off, read the paper, and do everything perfectly. It doesn't work that way. Next slide. So enhanced asthma education is important, but it's an incomplete answer. So if you look at published comparative effectiveness studies of asthma education, they show that baseline asthma knowledge is, quite frankly, low in high-risk groups. While education does increase knowledge, they can give it back to you in your office. It does not consistently improve asthma outcomes. So the thing is, if knowledge cannot be applied to a specific situation or scenario, that behavior never changes. And it was on this basis that we started to develop Not One More Life, which we'll talk about shortly. Well, again, going out of my field, Bandura is a famous psychologist. He's out of Stanford, talks a lot about cognitive theory and how people learn. And he shows 4 areas that are determinants of improved self-determinism, mastery experiences. So in my practice, what I would like to do is I had patients walk through the action plan. I mean, sometimes literally with, placebos and so forth like that. Social modeling. We did a lot with Not One More Life and getting patient advocates who they themselves were patients to show that this is how other people like you succeeded. And then social persuasion. This is what drew us to partnering systematically with the clergy and the schools and community organizations. So me being Black did not give me an automatic ability to convince Black people how they should take care of their asthma. But when I was validated in a relationship with a trusted source, I was empowered and the transference occurred. Also, it became obvious that when you talk to a lot of patients who are beset by disparities, it's not that they want to do that. They really are dealing with a lot of stress. So you show that what you're trying to do can reduce that stress. I may want the FEV1 to be a certain thing. They might want to be able to have a day out in the park. They might want to be able to go on a trip. They might want to not run to the emergency room all the time. So again, we have to have shared goals, and we have to look for that positive psychological response. Next slide. Okay, hold on just a second. All right, there we go. So Not One More Life was born about 25 years ago. And the story of this, very briefly, is that I had a young man, and I'm empowered by his family to give him his name, Kellen Bolden. I had trained at the University of Colorado, spent a lot of time at National Jewish during my fellowship. And shortly after I got there, Gary Larson, who was head of the division, called me and said, Leroy, have you seen Kellen? I don't know who Kellen is. He said, well, you need to see him. He is possibly one of the most difficult patients we ever had at National Jewish, which says a lot, because that was when they could literally, we used to call it incarcerating the patient for months to get the asthma in control. But aside from teaching the fellows, they found ways to do that. Well, Kellen had been there and had got the best National Jewish had to offer him. Okay, but he unfortunately died. And in the story, very quickly, is that he was at school. He was a middle schooler. He was at the point where he was very socially conscious of not being different. He had an action plan that I'd gone through with him, but he arrived from the school bus, a diesel-powered school bus, I might add, in mild distress. Someone asked him how he felt. He said he felt fine. He went to class, dressed out for PE, and collapsed. EMS was called. He had that very severe phenotype. They were not able to ventilate him. They intubated him in the field. They brought him to Grady Hospital, and he's pronounced dead. Okay. And unfortunately, that is not that abnormal a study. And this was a child that I had done everything, the family had done everything to really make a difference. Well, it became apparent to me that what we needed to do was educate and empower the environment around the Kellens. So Not When Life was started. And we did programs. In fact, we're still doing it. The network is now taking this over in partnership with communities of faith, health ministries, local schools, and other validated community partners. Because what people have to know, race is tied up in everything. But in reality, my being an African American is not as important as me partnering with someone who they have a trust relationship with. So what we did is we did individual case management. We did telephonic follow-up at 1, 3, 6, and 12 months. So if you came in, we found you had asthma, we showed you PFTs, which strikingly back in the early 90s when we started this, many of those patients were getting PFTs for the first times in their life. We referred people to existing clinics and community hospitals. We didn't pull all of them into my practice. We empowered, because a lot of them were adults, obviously, we empowered them to have informed relationships with their providers. We called providers and in a respectful fashion offered suggestions. We found many people, this is before Obamacare, that had no health care. So we got the Black churches and a couple other people to get together, and we started a free pulmonary clinic in Atlanta. We did medication assistance until the powers that be decided that that was a way of bribing us, which made no sense to me. And I found ways to get around that, which I can't say. But anyway, we put medication in people's hands, because if you're telling someone that it's important to do something and you don't do anything to address the hurdle of actually getting that medicine, then you've left them worse than you found them. We determined eligibility for CMS programs. When we went to New York to do a replication in an area in New York, the New York Health Department showed up because they'd heard about us and they said, you know what, these patients are high utilizers, so we want to partner with you. They thought it made sense. And we utilized patient assistance programs. And that was very important. Those are still out there. Again, this gulf that we have with pharma for all kinds of reasons, propriety, sometimes disconnects that, because I always had samples before and I'd put that, and I'm not going to use any names, but I'd put that controller, that combo medicine, that whatever in the patient's hands. And actually studies show that when we did that, adherence actually was enhanced. I can't quote the study, but I've read one. Just walking out of a doctor's office with a sample of the medicine they said was key increased threefold the likelihood that they'd actually take it. Next slide. Oops. Got two computers here going and I hit the wrong one. Sorry. So again, established in 2003, I've kind of told you this. We have successfully expanded it to 19 other US cities. Some of them have gone dormant as I don't travel as much as I used to. Not going to travel very much after this talk either. This is my swan song for you guys. But anyway, we were able to get 19 other US cities. And last time we checked, 2/3 of them were still doing some variation of Not One More Life. We had online patient and provider education through an industry grant, an unfunded grant, where we went around and did live CME in selected cities, targeted not just as your average asthma talk, and we didn't mention any drugs by name, but we'd go in and we'd teach providers, okay, this is what we do, this is how we do it. They'd have a nice fancy dinner with it, so we had their attention. So think about the drug talk that wasn't a drug talk, which we can't do anymore. We also, I told you, had that monthly community pulmonary clinic because we could bring these patients in Atlanta and get things started and then hook them back up with their provider. So what was novel about it? Well, the fact that we presented in partnership with the communities of faith. We did these programs in school gyms, in community meeting halls, and we clearly were respectful of the validated community partners. It typically consisted of a very short didactic presentation, shorter than the time I'm going to have with you here, because the mind can't absorb what the butt can't tolerate. And people don't like to sit around and hear you prattle on and on. But the important thing was we let them have a question and answer, and we respectfully answered those questions, even ones that as providers, we thought were inappropriate or just silly. And they weren't, because the only dumb question I would tell patients, the only dumb question you can ever ask a doctor is the one that you didn't ask because you didn't want to be embarrassed and walked out the room without the knowledge you needed. And I'm very militant about that still. We then screen the patients with a validated Juniper questionnaire and spirometry. And here's another take home. We found ourselves doing spirometry in moderate to severe asthma, and they told us that it was the first time they had that test. That's pretty frightening, okay? We had volunteers, pulmonologists like myself, but also allergists and primary care volunteers review the results with participants. This was a great way to teach primary care doctors how to read spirometry. And for a season, I got lots of help. Then they got smart and they knew how to read it on their own. We gave feedback to the primary care provider because we want to empower that relationship. We don't want to undermine it. And then we accessed these people to specialty care, and we were very deliberate. It went to my partners at Emory, it went to me, it went to the people at Grady. It wasn't a matter, it was just getting them into the experts. And then we did telephonic follow-up at 1, 3, 6, and 12 months, because in grant writing, I found out you can have the greatest idea in the world, but if you don't measure results, all you have is a hobby, and nobody's interested in your hobbies. All right, so let's switch to COVID. COVID, you could lay COVID on top of asthma, and it showed us exactly the same disparities, however, with much greater devastation. So this is updated as of a few days ago, thanks to my partners at, not at Johns Hopkins, my partners at the network who can do these kind of graphics. You'll note right off, here we are, the United States with the greatest healthcare system in the world, and we lead the world in cases and in deaths. And let me just say this, and this is my swan song, so if I'm wrong for saying it, so what? The politicization of COVID has been a force of death in our community. I mean, people, I live now down on the Panhandle, Florida, in a fairly affluent, resort area, and the politicization has got lots of people stuck and stupid. And we really need to move on for that. And I didn't mention any politicians' names or anything like that, but it's just ridiculous. But anyway, you see right now, we lead the world, okay? And we consider ourselves a country of distinction, but this is not a distinction that I think we should be proud of. Next slide. All right, this is looking at total cases. This was a data cut a little bit earlier. This is 25th of July. I'm sorry, they did update this. So the 7-day case rate is up again. Total deaths are up again. We are in a surge, no matter which brand of talking heads you want to look at night. We are in a surge. And I live in Florida, which is a dark blue on this and dark red. And again, we have politicians going around talking about freedom as people die because they can't get what they need. Makes no sense. I'm sorry. I'm not sorry at all. If we look at the case rate, we see how it spiked, and we see out here at the very end, if you continue that up, we're getting up to that level of 100,000 as we were before. And again, this is tragic because really, I mean, this is a bad bug, but public health practices matter, and it needs to be advocated by trusted messengers, which is going to get me into our next part. This is a coronavirus vaccine tracker. I deal as an African-American. I have lots of friends and so forth. I deal with this every day in conversations, okay? These vaccines were developed in rapid time because they had to be developed in rapid time. For the most part, shortcuts were not taken. And it's helpful to kind of sit down with patients and actually go through that with them so that they understand. Because vaccine hesitancy seems to be most prevalent in those populations who can ill afford to be so. So this is another slide, and this is looking at who gets vaccinated. And we're nowhere near that vaunted 70%. We now have youngsters coming on age. It's important. I live, this is not revealing because I'm not giving any names. Across the road from me is a family of 5, 3 children. And it was so important for the oldest child to go to a basketball camp 2 weeks ago in Philadelphia. And now the whole family has COVID, They're doing fairly well. They haven't gone to the hospital. I see them with my mask on. I mean, it's just things that knowledge could speak into, okay? But anyway, I'm not going to do this. You can see right now where we are at about 163 million people vaccinated. We're not where we need to be. The thing is, and we'll get into this shortly, is that these vaccines were not rushed, but vaccine hesitancies, and they were not rushed without purpose. I mean, they were rushed, but they expedited various scientific principles that have been used for generations, or not, or at least for a long time, in terms of vaccine formulation. The World Health Organization told us from the very beginning it's a major threat to global health. We know that vaccine availability has not guaranteed sufficient population vaccination, as evidenced by hesitancy, particularly among minorities, but also particularly remarkably among people who support a certain political group. And that makes no sense to me. Makes no sense to me. I mean, you have freedom, but you don't walk out in front of a semi, okay? And that's what this has got me concerned about. Previous research indicates that vaccine compliance remains variable and inconsistent. Successful inoculation clearly has to be widespread and has to be coupled with public education. And we have to stress that this is a safe and efficacious vaccine. All right, again, these are the numbers. It's not like vaccinations are new. I couldn't go to school without my polio and my smallpox. I'm 67 years old. This is not a new concept. Okay, but this is looking at acceptance rates in different populations. And guess what? Some of us medical providers are not any better than the people that we're taking care of. Well, we do know that people currently vaccinated against seasonal influenza, people that are used to getting vaccines, are willing to do that. The Army paid my way through medical school, and I spent 12 years in there. So I've been vaccinated for almost everything you know. I went to Desert Storm. I mean, it's not a difficult content. But acceptance for COVID vaccine among physicians and nurses overall is lower than acceptance rates of the seasonal influenza. And this gives a very dangerous mixed message to the people that we're trying to help and inform. Next slide. So, here's kind of a breakdown of what people are concerned about. And I'm going to show you a celebrity's opinion on this, who's a very good friend of mine here shortly, and how he handled this. But I mean, these are all, I'm not going to read this to you, but these are all things that I think are genuine contexts of concern. But what we as providers need to be able to do is to address these in a logical fashion. And that logical fashion is not waving a finger and saying, but telling them why the risk-benefit analysis on these vaccines is tilted toward benefit without question. But it's of greatest concern to both physicians and general population alike are fears of the safety, and given its rapid development. I tell people, my lay people, and you all know this, that the technology to develop this was not new. We had SARS, we had MERS, we had influenza. So it wasn't like we did this out of the world, cauldron kind of in a back room. So despite this general concept of community immunity achieved by high vaccination rates, even higher compliance is actually necessary among communities where individuals are at higher disease risk because of comorbid conditions, because of economic challenges, because of educational challenges. So here's the racial disparities, okay? So if we look at race, and this is an older slide, but basically we're seeing it click around at about 61% in whites, only about 12.3% in African Americans. Now that has improved dramatically. I've seen figures that's up to 28 to 30% now, which is kind of scary when you think that people of color and poor people are more at risk, okay? We look at the share of deaths, okay? Now that got to play statistics now. Black people are a much smaller percentage of the American population as whites, so 21% is nothing to feel good of, okay? We have about a 19% share of the cases. The Hispanics, I think, are even more prevalent in their disparity, as are the Asians, okay, who are less. But the Native Americans, this data I don't trust because I think public health and our Native American citizens is horrid. I don't think we really have our hands around that. You heard about early in the pandemic, these devastating numbers of deaths on the Indian reservations. And as mistreated as African Americans and maybe Hispanics have been, what we've done to the Native Americans is shameful. And we're seeing the epiphenomena. So those numbers that look really low, those numbers belie a very serious degree of disparity among Native Americans. All right, so how do we deal with this? Well, we deal with this by trying to create health equity. And I'm not going to read all that, but these are things that people have to have access to develop any kind of parity. And you'll see this. Now, an interesting thing that's happened with, and I live in a very conservative area and everybody thinks we shouldn't be sending people checks and all this stuff. But you know what? If you go on the news or Google this up, we have the lowest poverty rates in the history of this country. Now, a lot of that is due to the benefits of giving people money because of what's happened with COVID. But just think about that. I'd love to see 10, 15 years from now, getting people out of poverty, what effect that had, and if that getting them out is sustainable. But here are the things that we have to address. Discrimination, minority stressors, housing. Many people live in substandard housing. They expose them to all kinds of things. Educational opportunity. It's clearly, not a college degree, but functional health. We don't teach health the same way we did in schools when I was young. Quality, affordable care, Healthcare Act. You all know that when the immediate past administration, I'm trying not to use names, came into office, he said that he wanted to kill Obamacare. Obamacare, for whatever its shortfalls, achieved the highest rates of insured individuals in the history of our country. So that made sense to tear it down. Don't get me started. Okay. But that care has to have equality too. Neighborhood conditions. We know I grew up in Chicago. My dad was a cop in the Inglewood district. Inglewood to this day still leads the city in terms of violent deaths. So people live in this fight or flight situation because of the stressors that they're exposed to. That activates the sympathetic nervous system. This feeds into asthma. Okay, stable income and job security. I found patients who I was telling to do these things. I said, Dr. Graham, I got to keep my job. I got to do this. I got priorities. There's only so much I can do. We should never place people in a country of this wealth having to choose between keeping their job and providing adequate care for their children. It just makes no sense. And environmental quality. We don't have time to talk about that, but think about this. In most of our big cities, the central traffic corridors with 16 lanes of expressways, they go right through the poor neighborhoods, almost always. So COVID-19 basically didn't create these problems, it exacerbated. We knew that during this, there was increased housing instability, loss of income early in, people got put out on the street, okay? People lost their place to stay. And where did they go? They went to relatives, they went to friends. We had more overcrowding. You see what happened in New York, it spread like wildfire. Food insecurity, loss of income and limited supply of quality food in what was already known as food deserts in many of our urban areas. Social isolation and loneliness. Imagine that you have a low health literacy and you see people around you die and you begin to lose that beautiful thing called interacting with people. A lot of people really had lots of mental disease that made this worse. The digital divide, we tell everybody, oh, we're going to do virtual this, we're going to do virtual that. We did a study, or I didn't do a study, Morehouse did a study in Atlanta about 4 years ago about the percentage of, I think it was middle school families that had a computer that the child could use. It was 1/3 of that of white households in Metro Atlanta. So how did that work out? I know that in Atlanta, when the COVID started, I can block on his name, he's a great guy, who the owner of the Atlanta Falcons actually gave $10 million to the to the public school system in Atlanta to get computers and kids. There's only so many of those people to go around though. Prejudice and discrimination, differential access to basic and pandemic related health care. And I'm sorry, but the idiot in the White House, why would you call this Kung Fu flu? Why would you call it the China flu? I'm sorry, I know I tripped the wire there. I shouldn't have said that. And but things like this give mixed messages to people. All right, so let's talk about the impact of chronic disease. We know this, and this may be a review, but several factors in chronic disease have been shown to really be associated with poor outcomes. Just being old, I'm 67 years old, Early in this thing, I had an unscheduled visit with my internist. I have hypertension. I had an aortic aneurysm almost 30 years ago. I have a blessed St. Jude valve that works. So I got my butt into my doctor and say, hey, is everything going all right? Because I need to know. But we know that adults, just being older at 65 and over, have lower immune function. They have reduced ability to respond to infection. They have increased inflammatory responses that cause organ damage. And we know from talking to some of my adult ICU guys, they called COVID the great disruptor. It exploited a lot of inflammatory signals and did damage to critical organs like the heart, lung, and kidneys. And I would not do justice trying to explain the pathophysiology. Complicating pre-existing conditions. One of my neighbors, one of my colleagues rather, asked me, there's a very Tony hospital in Atlanta, I won't use the name, on the north end of town, which quite frankly is where I live. And I interviewed him for an editorial I did in Peds Pulmonary. And I said, what are you seeing up here in our neighborhood? It was I'm not going to say the hospital, but this hospital served a fairly affluent thing. He says, it's Hispanics, Leroy. And I said, well, wait a minute, there's not any Hispanics neighborhood. They're the people that are doing yard work. They're the people that are doing custodial things in your community, and they're falling over at work. So in that one hospital early on, it wasn't residents from that neighborhood, it was the people that serve that neighborhood. Complicating pre-existing conditions we know are more prevalent among a lot of these groups. Lung function decreases with age, superimpose that on the problem of access to or diagnosis of chronic disease and a disease that complicates your ability to oxygenate, it's a recipe for disaster. So some of the other impacts of chronic disease, we know this, I'm watching the clock, low socioeconomic status. These people were living in and continue to live in substandard, overcrowded housing, harmful environmental exposures, which probably fed into this, reliance on overcrowded public transportation. It broke my heart, as I hope it broke yours, early in the thing. We saw all the essential workers crowded, and I've rode the subway many times in New York. Just think, that was the ultimate super spreader. And we saw all those pictures of the morgues and the vans that had to be filled because the morgues were full. More likely to be essential workers in public facing service. So poor people, minorities, they're the ones in this first rush that were getting exposed to everything. And finally, because of the dissolution of the Affordable Care Act, at least in part, they had inadequate or no health insurance. But we're going to fix that now when we see the bill. So the other thing, weakened immune systems. this is, I'm not going to read this slide. It's obviously people on chemotherapy, immune deficiencies, organ transplants. These populations obviously are very susceptible because of concomitant immunotherapy. Other factors, we know that poorly controlled chronic lung disease. I'm talking to a bunch of asthma specialists, including asthma and COPD, particularly COPD in patients that had multi-organ dysfunction, okay? And it increased the chance for respiratory failure due to COVID. Poorly controlled heart disease or poorly controlled hypertension. My colleagues in the ICU said, Leroy, you know, when a guy comes in hypoxic and his blood pressure 220 over 150, I'm rolling that rock up the hill. And we know that a lot of these people died of secondary organ failure and so forth because of this. Poorly controlled diabetes was associated with a threefold increase in death. Obesity, which is an inflammatory condition, was associated with poorly controlled chronic diseases and a possible blunting or a limitation of the body's natural response to severe infection. Neurologic conditions, in the interest of time, I'm not going to read this to you, but things that basically compromise people's breathing. We know that will do that. Also, people with neurologic disorders who don't move around a lot, people that have swallowing dysfunction. All of these diseases are treated with anti-inflammatory medication, which may or may not, this is the dispute, did that hurt people in terms of not mounting a good body's response? My personal opinion, reading a limited amount of data, I think not being on that therapy and having a lack of control of those chronic conditions was probably more problematic than the minute amounts of anti-inflammatories. Pandemic stress, this is huge. There are people who are suffering from severe depression and anxiety. I'm 67 years old. I've always had a little bit of anxiety syndrome. I fought it, but I mean, when we got out, you're going to see in the last few slides, we went out and did some community work. I was anxious, still anxious, okay? I overcame that anxiety, but just think about what's happening to people who maybe don't have those same coping skills. We know that females in communities of color are 1.5 times more likely than males and whites to be concerned about household responsibility. Imagine trying to navigate your household in the midst of a pandemic with limited resources when you see the people around you literally dropping like flies. So parents were very more concerned about career impact and family household responsibility than non-parent employees. Practical challenge, okay? Just talking about asthma, we'll see this. I put this slide in here, it's not a COVID slide, but look at these things. All of these things have impact also on COVID, okay? And we needed early on to improve the, make sure I'm not getting hurry up notes. We needed all of this to be addressed to improve outcomes. And we're getting better, but we're still not there. So what can be done now? And this is what we did. We developed something called the Trusted Messenger Project. I forgot to announce that we have a COVID grant. We have a PCORI grant. We just got it renewed, and it was to actually look at asthma in Hispanics and African Americans and subsequently in Hispanics. It'll be the only thing I'm involved in after this talk is since I'm a PI on it. But basically what we did is we got this for asthma and we flipped the script and started doing things under COVID. And the people that at PCORI were okay with that. So access to COVID testing. Early on, we went into Atlanta when nobody could get tests. It didn't seem like it. Tons of tests out in the suburban and the white communities, or even the community I lived in. Very hard to get it. So we brought COVID testing early on. We also screened people for comorbidities. We had people, you'll see the lady there. I mean, this was tricky. People, my colleague said, you let people blow into a spirometer in the middle of a pandemic? Yeah, because I looked like that. I had all the stuff on. I didn't catch it. Okay, but we also found people who had cardiovascular disease and hypertension out of control. We found lung disease out of control, diabetes and so forth. We tried to the best of our ability to get those people into control, get them plugged in. We help people utilize self-assessment skills. That's the Asthma and Allergy Network is the leader in that. And we enhance the functional health literacy in the context of COVID. A lot of things we did, we spent time explaining why we were doing it to people. Next slide, I'm almost through. All right, so there's something called the health belief model. This applies to COVID and asthma. You got to believe, the patient has to believe that they're susceptible to the health problem, the threat imposed by that problem is serious, and the benefits of what you're asking me to do outweigh the cost. And the costs are not always monetary, the hassle factor. And what you want to leave that patient to the encounter, and this is what we do in the PCORI grant, is we want patients to leave confident in their ability to carry out recommended action successfully. Because really what you want them to be able to do it is under the maximum stress when it's called on to do that. And we know that beliefs influence that willingness to follow preventive therapeutic recommendations. So if you don't talk about the elephant in the room, it's not going to happen. So vaccine hesitancy, we're going to wrap this up here very shortly. I got 6 minutes by my clock. This is early on, and it hasn't changed a lot, and this is one of the things that pains me deeply. If offered a coronavirus vaccine free of charge, this was early when it started to come out, fewer than half of the Black people and 66% of Latinos said they would definitely have probably take it. In reality, it was about half of that in terms of who actually did it. According to a survey-based study that underscored the challenge of getting vaccines hit hard into communities hit hard by the pandemic. Shots in arms, okay? Black Americans, guess what? I don't know why, but historically we have a high level of distrust in the government. So they were not participating in large number in the early COVID-19 clinical trials. And I spent a lot of time talking to people about that you want to be in these trials. You want to make sure the therapy works for you. They were the most, still are the most hesitant group to get a vaccine once one is available. Skepticism rose. I want to get through here. These are just important people who got a vaccine. That's fine. I want to get to one thing. We have work to do. We need to vaccinate a large share of the US population. We're still hovering at a level that's not going to bring us herd immunity. We need to address continually the trust in the vaccine uptake. I think that's getting better. It will take all of us. One political thing, when Sean Hannity on Fox News says people should get a vaccine, thank you, Jesus, okay? So this is a trusted messenger. I'm gonna wrap this up in the last 5 minutes, okay? This is what we did out of our PCORI grant. We went into the inner city and we did for COVID early on, what we had been doing for asthma under the same grant. We had a pharma partner come alongside us, which helped us increase our bandwidth. We showed data like this, not this slide, went in and taught people about the increased mortality rate for African Americans and other races. We showed them that Black Americans had experienced at that point 20% of all COVID-19 deaths, but represented only slightly half that percent of the population. That's a disparity in a nutshell. All right. So one of the things we did, we went on TV and I got to be on TV and film that guy, that handsome guy, not me, the old guy in the sport coat, but the guy to the right. That's Montel Jordan. This is how we do it guy. He's actually a minister at a church I belong to. He does a marriage mastery kind of thing. He's just a really cool guy. But he was that trusted messenger alongside Dr. Graham that helped when this video went out around the country. What we want to do is empower lifestyle changes and healthy behaviors through education. We want to address the barriers, translate patient data into insights, okay, into personalized solutions. So on the right there, you see some of the things we were doing. This is, I think, our second or third program. We did a lot of digital innovation. If you had a cell phone, you could get on our site and get information about that. This is another picture we did at another church. This was amazing. We also gave people free food. You know, this is early in the pandemic in October and so forth. So we gave people food. We were able to show people that we cared. We were able to do screening. And again, we emphasized the importance of making sure chronic disease was controlled because we knew that was a huge risk factor. All right. This is kind of from our website. Okay. And again, this is what people went to get information. This is our update. We're continuing the digital outreach. We're now over 300,000 patients reached. I'm not traveling with them anymore, but they just did Chicago. They saw 500 people at a charitable clinic. They gave out 250 vaccines. Praise God. We did do the live event at Ebenezer, but the Chicago thing that we just did last week was probably our best. And we're still looking at these other cities to go into. Chicago, we've already done. So who's taking the vaccine? All right.
Dr. Graham, we have about 20 seconds left.
All right, well, here we go. Dr. Graham took it, okay? Montel Jordan didn't take it, but I talked to him today and he just took it after he got a mild case of COVID. All right, Dr. Bridget Jones, Office of Health Equity and Diversity, she did it right off the bat. And I think that's it. How's that for 20?
All right, and where's my non-medical room? There we are, okay. All right, so folks, welcome back. We have actually managed to make these breakouts work just fine. It's taken a bit to resolve some folks' issues with getting into your rooms, but we've got a good process now. So if you want to stay in the room that you were in before, you don't need to do anything. Just sit tight. You'll be put back in automatically when I open the rooms for the third session. Before I do that, though, I need to find Dr. Stanley Scheffler in my participants list so that I can assign Stanley, there we go, as a co-host so that Stanley will be able to share slides in their breakout